I am Dr. Angela Mushabi, National Coordinator for the Prevention of Mother-to-Child Transmission of HIV and Pediatric HIV Care and Treatment in the Ministry of Health and Child Care. I'm also chairing a session in the upcoming International Conference on AIDS and STIs in Africa, ICASA. With respect to prevention of mother-to-child transmission of HIV, this program has been in existence since 1999. When it started, it was only in 3 pilot sites. In other words, it was early days of the HIV epidemic, and the country had not yet rolled out antiretroviral treatment. So only 3 facilities in 1999. From 2002, this program was rolled out nationally. In other words, the pilot was successful, and it was recommended that we need to reduce the transmission of mother-to-child transmission, and this service doesn't have to be restricted only to a few sites, but that it can be spread throughout the whole country. As I'm speaking, these services are available in almost 1,700 facilities countrywide. What it basically means is all services that offer pregnancy care are able to offer prevention of mother-to-child transmission of HIV. We have seen in the programs that we need to train healthcare workers. And when we started, we were only using nevirapine. Imagine just one antiretroviral given to the mother at the onset of labor, and then another single dose of nevirapine given to the infant when the infant is born. Because when the infant is born, we say it is an HIV-exposed infant. At that point, we don't yet know whether the child will test positive or negative. So early days, we were only giving just that much. But as time has progressed, we are now using triple ARVs to the HIV positive mom. So we give tenofovir, we give lamivudine, we give dolutegravir. Now these 3 antiretrovirals are contained in just 1 pill. So with 1 pill a day, that is full treatment for the mother. Remember, we had said it used to be single dose at the onset of labor. This one, we actually encourage that mothers book early within the first 3 months of their pregnancy. And if we test them and they are positive, we put them on these 3-in-1 antiretrovirals contained in 1 tablet. They take it throughout the pregnancy, throughout the breastfeeding period, and for life. Because not only do we want to prevent the infection from getting to the infant, we also want the mother herself to be in good health. So we do not discontinue the antiretrovirals at the end of breastfeeding. She continues being on treatment for life for her own health, and then also for the prevention of mother-to-child transmission of HIV. So that is how the program is evolved. So essentially what that means is capacity building of all healthcare workers in our health institutions so that they are able to offer this medication. They are able to counsel women in the proper manner that they need to have this HIV test. And in our facilities, we find that the majority of women, 99% or almost, accept to have the HIV test, and they have their results, and then they are put on antiretroviral treatment. So that is what we are doing. We also need to make sure that the supplies that are required of these medications are available. And we not only focus on the mother herself who is HIV positive, we also focus on the HIV-exposed infant at birth. So the HIV-exposed infant is also started on antiretroviral prophylaxis. We call it postnatal prophylaxis to the HIV-exposed infant. And the infant will take this for 12 weeks. And then after that, we will discontinue the postnatal prophylaxis. I did mention that we would say HIV exposed. Now we want to establish the child was exposed, yes, but is the child HIV positive or negative? And for that, we have access to a PCR test for the diagnosis of HIV infection, which we actually encourage to be done at birth. Within the first 72 hours, we will know whether the child who was exposed and whose mother went through the PMTCT program, this program was successful and the child is negative. So we will know that at birth. If after we test at birth, the child is positive, we can initiate the child even at that early stage on antiretroviral treatment now, not just prophylaxis, treatment with 3 antiretrovirals to the young infant that is tested HIV positive. However, if the child tests HIV negative at birth, we administer another PCR at 6 weeks. In our population, we promote and we support breastfeeding. So most of our mothers are actually breastfeeding their babies right through to 24 months and beyond, as is the policy of the Ministry of Health and Child Care. So we will repeat testing at 6 weeks with a PCR test. And if the child is negative at 6 weeks, we do another PCR test on the infant at 9 months to establish whether the child has remained negative. And we will confirm the HIV test after 18 months when we can use rapid antibody test. We have seen lots of successes. I think a lot of people now recognize that just because you are HIV positive, it doesn't mean that when you give birth to your child, the child will be HIV positive. There are many success stories, and we have people who are giving testimonies to the success of this program. So it's very welcome, and we would hope that more people out there become familiar, particularly the young people. I talked about testing in pregnancy. How about testing before you even become pregnant? So you know your status, and then if you are HIV positive, even before you are pregnant, you are put on antiretroviral treatment for life, and then your viral load is suppressed, and then you are in a good place to fall pregnant.